Now I'm absolutely delighted to host the Presidential Symposium entitled Delivering on the Promise and Future of Genetic and Genomic Medicine, Not a Sisyphean Task. Before I start, I have to note that this session is not eligible for continuing education credits. So, when I thought about what would be the topic of the Presidential Symposium, I thought it was appropriate to build on my presidential address, as many of you heard. And I think to really focus on looking to the future and build on what we've done in the past 75 years. And I can think of no three greater or best speakers as we have luckily today, Dr. Don Cohn, Dr. Dennis Lowe, and Dr. Fumi Olopati. First, I want to ask them to come up and take a seat to my left, please, as I introduce them. As you'll see, they really will demonstrate the great science that has empowered the history of our society and the present. Oftentimes the public asks, what has genomics and genetics done for us? And simply put, it is the power of diagnosis and the power of therapy. And that's the message we should be communicating to the public. And I think these three individuals demonstrate, in fact, the deliverable now and in the future of those things in the context of genomic medicine. In addition, I think they will touch on the obstacles I touched on in my own presidential address, that we need to ultimately get this amazing technology to everyone everywhere, which is part of what we have committed to do as a society. But it is not a Sisyphean task, because I think we are making progress, and while it is a difficult road moving forward, we together ultimately will come out with the strategies to achieve that, and I hope that that message comes across. Let me introduce each of them, and then they'll come up sequentially to give their talks. So Dr. Dennis Lowe is the Associate Dean of the Faculty of Medicine, the Director of the Li Ka-shing Institute of Health Sciences, and Li Ka-shing Professor of Medicine at the Chinese University of Hong Kong. His research focuses on the biology and diagnostic applications of cell-free nucleic acids in plasma. In particular, he discovered the presence of cell-free fetal DNA in maternal plasma in 1997, and has since been pioneering non-invasive prenatal diagnosis using this technology. He's also made many innovations using circulating nucleic acids for cancer detection. In recognition of his research, Dr. Lowe has been elected as a Fellow of the Royal Society, Foreign Associate of the U.S. National Academy of Sciences, Fellow of the World Academy of Sciences, founding member of the Academy of Sciences of Hong Kong, and has also won numerous awards, including the 2021 Breakthrough Prize in Life Sciences and the 2022 Lasker DeBakey Clinical Medical Research Award. Second, Dr. Donald Cohn will speak. Dr. Cohn is a distinguished professor at the University of California, Los Angeles, and a pediatric bone marrow transplant physician. He's performed laboratory and clinical studies of gene therapy for blood and cell diseases, especially primary immune deficiencies and hemoglobinopathies. His research has focused on developing improved methods for adding or editing genes in hematopoietic stem cells and evaluating these approaches in early phase clinical trials. Dr. Cohn was a recipient of a Distinguished Clinical Scientist Award from the Doris Duke Charitable Foundation, is a past president of the American Society for Cell and Gene Therapy and of the Clinical Immunological Society, and he's received the Outstanding Achievement Award from the ASGCT in 2022. And finally, Dr. Fumi Olopati is the Walter L. Palmer Distinguished Service Professor of Medicine and Human Genetics and the founding director of the Center for Clinical Cancer Genetics and Global Health at the University of Chicago Medicine. Her research is focused on gaining a better understanding of the root causes and genomic basis of cancer in diverse populations. She's published extensively on genetic and non-genetic risk factors of breast cancer and is internationally renowned for her work in inherited cancer syndromes and clinical expertise in early detection and prevention of breast cancer in high-risk women. Dr. Olopati has been elected to the most prestigious academies and societies, including the National Academy of Science and of Medicine, the American Academy of Arts and Sciences, and the American Philosophical Society. She served 6 years as a member of the National Cancer Advisory Board and chaired the subcommittee on global cancer research under the Obama administration. Dr. Olapati has received numerous honors and awards, including honorary degrees from several universities, including the 2021 William McGuire Memorial Lecture Award and the Franklin Roosevelt Freedom from Want Medal. The Order of Lincoln, the Officer of the Order of Niger, and the 2005 MacArthur Fellowship. So I'm delighted that they were able to make it and to talk about this important topic. Let's start with Dr. Lowe.
So, good afternoon. It's my great honor to be invited by Dr. Brendan Lee to participate in this symposium. So I'd like to talk about some of our work on cell-free DNA in plasma. So these are my disclosure slides. In 1997, my group first reported that during pregnancy, a fetus would release its DNA in the bloodstream of the mother. And this self-circulating cell-free fluid DNA can be found early in the first trimester. And actually, by the 10th weeks of gestation, the fractional concentration already reaches some 15%. And we and others have investigated use of this source of fetal material for non-invasive prenatal testing. Now, for example, for a variety of chromosome aberrations, such as trisomy 21. So in 2008, we developed a method whereby we randomly sequence millions of DNA molecules in plasma, and then we map them to the chromosome from which it comes from. And from this, we're able to measure very accurately the ratios of different chromosomes. And by using this method, we were able to detect fetal Down syndrome with a diagnostic accuracy of over 99%. So this method was very rapidly introduced in the clinical practice since 2011, and now is available all over the world, and millions of tests were done every year. And also because of similarity of the fetus growing inside mother to a certain aspect with tumor growing in a cancer patient, we also wonder whether this technology can also be used for the early detection of cancer. So for example, we have actually used genome-wide bisulfite sequencing to show that actually we can profile cancer-associated epigenomic aberrations in plasma. Now, for example, in this series of circus plots, the outer ring is a methylation status. And each time you see a red dot, that means it's an aberrant methylation that we are seeing. So you can see that by using this technology, one single blood test can be used to detect multiple types of cancer. And then in the ring here, we can see the copy number aberrations that we can also detect it in multiple cancer types. And also because different tissues in our body have different epigenetic profile, we can also use this technology to localize the tissue of origin of the detected cancer. So what we do is that we do genome-wide bisulfite sequencing, and then we compare the result with a reference methylome of different tissue types. And then through a process that we call plasma DNA tissue mapping, we can then tell what are the tissue which are releasing DNA in plasma, and in so doing, can localize the source of the tumor. And by using this combination of technologies, technologies have now been translated into a new generation test called MSET, which is multi-cancer early detection test. Now, for example, recently, Nicholson et al. Have reported one of their latest study in this area. So they actually use genome-wide methylation profiling on over 6,000 individuals with an average age of 62 years. And they find that by using this technology, they could have a positive predictive value of cancer detection of over 75%, and a negative predictive value of over 97%, and the accuracy of the tissue of origin determination to be over 85%. But the major weakness of this approach so far is that the detection rate for early stage cancer, like stage 1 cancer, currently is just above 24%, with the detection rate increasing with the stages of cancer. But apart from the sensitivity issues, there's also a number of diagnostic issues that we have yet to solve. Now, for example, whether detection of those cancers actually translate into survival benefits. And secondly, is what is the implications of false positive results. So we think that actually to answer those questions, it might be easier to actually target a single cancer than starting off with multiple cancer detection. So we decided to focus on a head and neck cancer called nasopharyngeal cancer, or NPC for short, which is a common cancer in the southern part of China. And one reason why we choose this cancer is because this cancer is associated with Epstein-Barr virus. And so we can actually use Epstein-Barr virus DNA as a tumor marker in the plasma. Now, for example, we've shown that the patient with NPC, actually, the plasma is stuffed full of this virus DNA. You can see on the left-hand side. And the right-hand side individual without cancer is generally negative. So we thought that it might be interesting to actually use this technology to screen for this cancer in asymptomatic individuals. So the screening protocol involved taking a blood sample and then testing it for plasma evDNA. If the test is negative, then the screening stops at that point. But on the other hand, if it's positive, then we'll wait 4 weeks and take a second sample and then retest. If only when both of those blood samples are positive, then we'll go for endoscopy and MRI. Now, so you can see that in this type of screening protocol, there are theoretically 2 ways you can have false positive result. One is individual who was positive in the first blood test, but negative in the second one. We'll call that transiently false positive. The second type, in which both blood tests are positive, but yet the patient doesn't have cancer. So we call that persistently false positive. And I'll talk more about those false positivities later on. So by using this protocol, we have successfully screened over 20,000 subjects between age of 40 and 60. And in the end, we found 34 cases of nasopharyngeal cancers. So you can see on the left-hand side, an individual without this screening. You can see that most of the cases is in stage 3 and stage 4. But on the other hand, on the right-hand side is what happens if we use this plasma DNA screening. You can see that we've changed the stage now to mostly in stage 1 and stage 2. And furthermore, we find that for the survival of the screened subject, of the 34 individuals, only 1 succumbed to disease. The other basically were cured of the disease. But on the other hand, in the bottom line, if the individual not screened, then we find that over long term, some 40% of them died. So now with this type of screening, will allow the reduction of mortality by 10 times. So this work was published in the NEJM in 2017. But one question we ask is, what are the clinical significance of those type of false positivities that I mentioned to you just now? So in order to answer that question, we have recently actually conducted a second round of those screening, 4 years after the first one. So in the end, 89% of subjects came back for the second round screening. And through this screening, we were able to find 24 additional cases of NPC. Now, so on the left-hand side is the people without screening. So as we see, most of the people are from cancer from stage 3 and stage 4. And the middle bar here is from this round 1 screening, which I've already reported to you. On the right-hand side is a result of a second round screening. You can see once again, we're able to detect cancer mainly in stage 1 and stage 2. And you can also compare the middle and the right-hand bar. You can see that by 4 years after screening, basically risk profile has reset back to normal. Now, in order to see what is the significance of the false positivity types, we actually take a look at the data in the first round screening, which can be either negative or transiently false positive or persistently false positive. And then we see what happens to those individuals at the end of second round screening, how many individuals there are and how many of them have cancer. And then we find that if you use the negative people to be the baseline as 1x risk, then we find an individual with a transiently false positive have a 4.4 times increased risk of cancer 4 years later. But on the other hand, if it's persistently false positive, they have over 16 times the risk 4 years later. So in other words, what it means is that the so-called false positive are not false at all. They're basically a marker of the risk of future development of this cancer. And furthermore, we wonder whether this type of observation can be generalized to other cancer types. And finally, also whether this will allow us to personalize this screening in some ways. Now, for example, if you're negative, we could afford to screen the individual every 4 years. If it is transient false positive, we need to screen every 2 years. But if it's persistent false positive, we may need to screen on an annual basis, just like we change the frequency of colonoscopy depending on whether we can find polyps. And next, I'd like to talk a little bit more about some of the new research direction in cell-free DNA areas. Now, when we look at DNA inside cells, we're talking about chromosome length DNA. But however, the DNA in the plasma are fragments of DNA. Now, for example, we sequence maternal plasma for fetal DNA. This is what we find. The x-axis here is the size of molecules, and y-axis is the frequency of those molecules. We can see the fetal DNA is in blue. The modal size is about 140 base pair. When you look at the mother's DNA, which is the red line, then the modal size is about 160 base pair. That means the fetal DNA is a little bit shorter than mother's DNA. And the same thing actually happened in cancer DNA, which is also a little bit shorter than non-cancer DNA. So recently, we've been very interested about this fragmentation, which now is generally called fragmentomics. So, and fragment size is one of the first fragmentomic markers. And by using fragment size, we can calculate what is the fraction, fetal DNA fraction in plasma. We can also use it to improve the screening accuracy of fetal chromosome aneuploidies. And also because the fragmentation is generally mediated by nucleases, and the nucleases have actually sequence preference when they cut, then we can also look at the end motif sequence to try to see which is the nuclease which is responsible for generating this particular DNA fragments. And those expression of those nucleases are aberrant in certain diseases like cancer. And we can also look at the jaggedness of the fragment ends, whether it's double-stranded or whether it's single-stranded, which once again is a reflection of the activities of different nucleases. So just want to give you one example of how we use fragmentomics. Now, for example, just I was showing you the power of plasma epigenetic profiling. But most individuals, if they want to get metabolomic data from plasma, they'll use bisulfite conversion, which is generally a rather destructive process. So we've been thinking, is it possible that we can replace this bisulfite conversion step? So it's wondering, is it possible that DNA methylation status might somehow affect the fragmentation of the DNA in plasma? So we decided to actually align all the plasma DNA, and actually we look at the coordinates where we have a CpG site, and we put a C in position 0. Interestingly, we find that if the plasma DNA fragment is methylated, as indicated by black dot here, then there's an increased chance that the DNA will be cut exactly at the CpG site. But on the other hand, if it is unmethylated, then the probability reduces a lot. And we can compare that with the -1 position when you can see the two lines are flipped. So by thinking about this, and then I've come across this particular idea of fragma, called fragmentomics-based methylation analysis. Basically, what we look at is to look at the CGN versus the NCG. And then we find that if the DNA molecule is methylated, then the CGN is high and NCG is low. But on the other hand, if it's unmethylated, then the CGN is low and NCG is high. So now it's just by looking at the ratio of CGN and NGC, you will have been able to actually profile, obtain epigenomic information in plasma. Now, for example, here, if you look across the whole genome, for the ratio, this motif ratio, CGN also NCG ratio, for methylated CpG site is about 4.7. But on the other hand, if it is unmethylated, we're just above 1. Now, for example, you can apply this sort of technology to look at loci which are genomic imprinted, like the GNAS locus. Like in this individual, one allele, the A allele, is methylated. The G allele is unmethylated. When you look at the CGN to NCG profile of those alleles, you can see that basically they're in reverse position. And by using this technology, we can detect cancer in plasma. For example, like in hepatocellular cancer, on the x-axis here, we measure cell-free tumor DNA by using copy number aberrations. And the y-axis, you use this CGN and NCG ratio. And you can basically see there's a straight line correlation. And we also show that this ratio is reflective of the stage of the cancer. So basically, by using this fragment technology, it's a way to unlock the metabolomic information easily. Now, in the final few minutes of my talk, I'd like to talk about, now, most of the people, when they sequence plasma DNA, generally use a short-read sequencer. But however, recently we're wondering what would happen if we use a long-read sequencer like single-molecule real-time sequencing. And we find that, for example, with short-read sequencer, you only see very short molecules. But however, when you use a long-read sequencer, suddenly you see that in plasma, there's a population of very long kilobase length DNA. Actually, if you look at pregnant plasma, then you can find that those long DNA represent about a median 15% of all circulating DNA, increasing to 20% second trimester, increasing 30% in the third trimester. So some of those molecules are kilobase length, like this cell-free field DNA is 16 kilobase. So with one cell-free DNA molecule, we can already haplotype the baby. And this one is from a mother, is 24 kilobase long, and one molecule I can obtain maternal haplotype. And also we find the same thing can happen in cancer, in which there are also kilobase length tumor DNA, and they also contain mutations. So the significance that would be like for the last 25 years, we've just been looking at short messages, text messages from baby and from the cancer. But now, for the first time, we can see a whole Word document sent to us by the baby and mother. So in summary, hope I've convinced you that certain DNA analysis has created a certain paradigm shift in molecular diagnostics. And there are some similarities between pregnancy and cancer. And non-invasive prenatal testing is already a standard of care. And there's an emerging application in cancer area, like for this multi-cancer early detection, and then new research direction, including fragmentomics and long cell-free DNA. So finally, I'd like to thank individuals from my group for generating the data which I present to you today. Thank you very much.
Welcome, Dr. Don Cohn.
Thank you, Dr. Lee, for inviting me to give this presentation. So I'm going to talk about hematopoietic stem cell gene therapy for inherited blood cell diseases. These are my conflict of interest. I will talk about an ADA skid vector that my university has patented. So gene therapy is, as you all know, over the last decade or two has really made great advances. And just to look at how it's done, it can kind of be divided into in vivo and ex vivo. And in vivo is probably the most common form currently, most commonly using adeno-associated viral vector. A small parvovirus can carry about 4 kb of DNA, and it can either be injected, for example, into the retina, injected intravenously and find its way to muscle, to neurons, to hepatocytes, and express its payload. Also, gene editing now can be delivered in vivo using those viral vectors. In contrast, for the ex vivo, for cells that are going to proliferate a lot and can be taken out and reinfused like hematopoietic stem cells and T cells, primarily clinically lentiviral vectors have been used for their ability to integrate and persist as the cell divides. And then sort of the new kid on the block that everyone's excited about are lipid nanoparticles. Similar to what's been used in the COVID vaccine, they can be used to deliver mRNAs or other nucleic acids, either ex vivo or in vivo. But I'll concentrate for most of the talk about hematopoietic stem cells, ex vivo as a target. But this is a slide I actually borrowed from Kathy High that talks about just in general gene therapy and how it's different from other therapeutics. And one of the main points is that gene therapy primarily is given just as a single one-time treatment, not a repetitive ongoing medical treatment. So there's a brief period of intense medical management, but ideally followed by attainment of a new health status that dramatically reduces the need for ongoing medical interventions. And this has led to treatments for diseases that previously lacked any pharmacologic treatments. And in fact, the initial products were really approved on the basis of trials with only a few dozen patients, which really shows the power of supplying the missing gene to the correct target tissue for single gene disorders. And so this slide lists some of the gene therapies that are approved in the US or in Europe. And so the first one approved, Luxturna, is an adeno-associated virus for a retinal dystrophy, and it has been shown to restore visual function. So I think it's just important to stop for a minute, and gene therapy has improved vision in patients. That, I think, is pretty amazing. And similarly, Zolgensma for spinal muscular atrophy, or some other gene therapies for adrenal leukodystrophy and metachromatic leukodystrophy have really profoundly improved the neurodevelopment outcome of patients compared to their siblings. So we have therapies that can really change these previously untreatable diseases to diseases where the patients have quite good outcomes. 2 therapies for hemoglobinopathies treating either beta thalassemia or sickle cell disease are very close to approval in the US and in Europe. In fact, one is already approved for beta thalassemia. Similarly, using adeno-associated virus to deliver clotting factor genes, primarily given intravenously where it will mainly go to the liver, can eliminate the need for lifelong clotting factors. Sarepta for muscular dystrophy was recently accelerated approval. It can preserve and improve muscle, although it's still not clear how good it is and how long it will last, and it's still under therapy. But gene therapy has worked for a whole number of other medical conditions, neurologic diseases, muscular dystrophies, et cetera. And so I think, again, we should just kind of pause it. That's quite an advance from, I've been in the field for almost 40 years, and about 25 of which nothing worked. So it's really nice to see so many different approaches that are clinically beneficial. And so I'll talk about the area that I work in, which is hematopoietic stem cells for blood cell diseases. And we've known for 4 decades or so that transplanting the blood-forming hematopoietic stem cells can cure genetic blood cell diseases. And so this is the typical slide shown of blood cell formation. On the left are the hematopoietic stem cells, which for lifelong will self-renew their pool or differentiate into all the mature blood cells you see on your right. And these stem cells postnatally are in the bone marrow. At the time of birth, they're in circulation in the baby's umbilical cord blood. And most commonly, clinically now, we actually mobilize them with some cytokines to go into circulation. And so, I think of that the stem cells are the babies with their whole lives ahead of them. The teenagers that are just progenitors who divide. And then the adult cells are the ones that do the real work. And we can transplant stem cells to treat the whole list of diseases that are here, and this is only partial. And so for neutrophil disorders, platelet disorders, red cell disorders, immune deficiencies, giving genetically normal stem cells, either from a healthy donor or from the patient genetically corrected, can treat a whole variety of blood cell diseases. And the procedure is sort of cartooned here, where stem cells are collected from the patient, so they're autologous. In the laboratory, they're either modified by adding a gene, like with a lentiviral vector, or now more commonly, or more recently, editing the gene using things like CRISPR. The patients are often then given some chemotherapy to eliminate some of the remaining stem cells in the body, and then the corrected ones are reinfused, where they can engraft and take over blood cell function, hopefully for the life of the patient. And then this just shows sort of the procedure. So collecting peripheral blood stem cells by leukapheresis, taken to a GMP laboratory where they're processed to enrich the stem cells. Then they're cultured either to add the gene with a lentiviral vector or to edit it, for example, with CRISPR. And then those cells can be cryopreserved, fully tested to make sure that they meet all the release criteria for sterility, potency, identity, et cetera. And then they're given back to the patient just by an intravenous infusion. And so the disease that I've kind of worked on since I was a fellow at the NIH, again about 37 years ago or so, is adenosine deaminase deficient SCID. And I'll just tell you a little bit about it because I think it illustrates sort of the strengths and the challenges of the field. So severe combined immune deficiency, or SCID, is the congenital absence of T and B cell function. And until there were therapies, there was uniform infant mortality due to severe opportunistic infections in the first year or so of life. ADA deficiency is the cause of about 15% of human SCID from more than 20 different genes that can give the same clinical syndrome of the severe immune deficiency. And that translates to about 8 to 12 born per year in the US and Canada. So it's not the public threat of our time, but it's still a very informative disease to study. And it's the first genetic form of these 20 or so forms of SCID where the biochemical genetic bases were determined. And we now know that ADA SCID patients have profound panlymphopenia, absence of T, B, and NK cells, from accumulated lymphotoxic deoxyadenine metabolites. So the substrate for ADA builds up and makes metabolites that are toxic to lymphocytes. So the patients can be treated with an allogeneic stem cell transplant from a donor, matched sibling donor, matched unrelated, or haploidentical. There is an enzyme replacement therapy, pegylated enzyme ADA can be therapeutic, or there is now autologous stem cell transplant with gene therapy. And so out of many iterative productions of vectors for this disease, this is the one that we've been working with now for the last decade or so. So it's a lentiviral vector. It carries a codon-optimized human ADA cDNA, so it can express the protein. It has a relatively weak promoter for the elongation factor gene, but by tweaking the cDNA, by codon-optimizing it, and putting in this WPR element to stabilize the message, we get a lot of ADA made per copy of this vector, and it has a very good safety record to the present time. And so we did clinical trials in collaboration with Claire Booth and colleagues at University College London, Great Ormond Street Hospital. We published the results of 50 patients with ADA SCID that we treated, 30 in the US and 20 in the UK. And this slide shows the event-free survival, that is surviving without needing a second therapy. So the blue line is the US, and we had one patient where just the cells didn't take early on and needed a transplant. And one patient in London, by about a year, they concluded that they hadn't had a very good result. So it was 96% event-free survival. and very nice immune reconstitutions. This is showing just T cell counts in the blood over time after gene therapy. You see by 6 to 9 months, the T cells are up into the normal range. And these cohorts were treated 6 to 10 years ago and continue with unchanged good immunity, good gene marking in all their blood cells. And so, as I said, among the 50 patients that we reported, there's been 100% survival and 48 achieved significant or sustained immune reconstitution 6 to 11 years out. And so this therapy, once you've proven it in research, it needs to become a drug. And so we've obtained several of the FDA designations, orphan disease, breakthrough therapy, rare pediatric disease, to accelerate the regulatory review. And so back in 2017, this was licensed out of our 2 universities to a biotech company that was started basically to take this to commercialization and marketing approval to make it available. However, the company basically failed to get that done over about the course of 5 years, and they returned the license to our universities last year. And during that time, we accumulated a waiting list of 30 patients waiting for this therapy. And so now, in fact, we're performing clinical trials using mobilized peripheral blood to treat the patients, but we're looking for a pathway to make it sustainable. We're still on the remnants of a grant from a number of years ago. So then I want to talk a little about sickle cell disease that, again, has seen great progress in the field. And so just one slide of background. Sickle cell disease affects about 100,000 people in the US and millions worldwide, disproportionately affecting minorities, so about 1 in 500 people with African American ancestry and about 1 in 36,000 Hispanic American ancestry, and as I said, millions worldwide. And it causes severe medical complications of sickle pain, acute chest syndrome, splenic infarcts, renal failure, strokes, so that despite the best medical care, recent published literature suggests an average lifespan of about 45 years with sickle cell with best medical care. And so this is one slide, the pathophysiology. So red blood cells are packed with hemoglobin. I think it's 20 micromolar protein. And the amino acid change in everyone with sickle cell is the 6th amino acid is changed from a charged glutamic acid to a nonpolar valine. That nonpolar valine shown on the right actually can then connect with a nonpolar pocket on an adjacent hemoglobin molecule, leading to aggregation and polymerization of all the hemoglobin molecules, so they come out of solution, and the very flexible red cell that can squeeze through capillaries becomes rigid and sickle shaped and causes vaso-occlusion and hemolysis. And so you probably are familiar with the beta globin locus. It's been studied very much. So from your right to left, the beta and delta are the adult globins, then the gamma chains are expressed during fetal life, and epsilon is the embryonic form. And throughout ontogeny, then that locus control region of hypersensitive sites, sort of the super enhancer on the left, serially interacts with epsilon, then gamma and beta to switch which globins are made through development. And adults mainly express beta globin, but in fact a small amount or variable amount of fetal globin may persist lifelong. And it turns out that fetal globin with the gamma chain is anti-sickling. So where beta has that hydrophobic pocket for the valine to stick to, fetal globin has a charged amino acid, T87, and that repels the sickle chain, the sickle chain. So a small amount of fetal globin has a very potent anti-sickling effect. And that was first realized clinically now 30 years ago, where a study was done just looking at people with sickle cell, measuring how much fetal hemoglobin they express spontaneously, and breaking them into those below and above 8.6%. And those with the higher levels of fetal hemoglobin lived a decade longer. So it really has very strong disease-modifying activity. And we now understand sort of how this switch is made from fetal to adult globin. So this shows the locus control region in the fetal state associated with the fetal globin chain, whereas in the adult globin, in the adult stem cells, a transcriptional factor, BCL11A, is expressed, which binds to the fetal globin chain and prevents the LCR from binding there, so then it moves over and interacts with the adult globin chain. And so it turns out that if you don't have BCL11A, you express high levels of fetal globin. So this suggests a therapeutic strategy to treat sickle cell and alpha thalassemia by turning on fetal globin. And so there's a variety of approaches that are being looked at for gene therapy for sickle cell disease. One, for example, would be to make a lentiviral vector to express gamma globin because it's anti-sickling. In fact, what's been done most commonly is using the beta globin gene with a single or a few amino acid substitutions from gamma globin. And so T87Q is a substitution in Bluebird Bio's anti-sickle beta globin. We worked with one with has 3 amino acid changes. And then David Williams at Boston Children's has used a lentiviral vector to express siRNA to knock down BCL11A expression. Then more recently, there's a number of approaches not using gene addition, but using gene editing that I'll talk about it a bit at the end, but just to say that you can use, for example, CRISPR-Cas9 to make a cut in the BCL11A erythroid enhancer, and then it'll get insertions and deletions and disrupt the function. You can do the same thing to where it binds in the gamma globin gene. Base editing, a newer approach, can be used to actually change the sickle codon valine to a benign codon, not the wild type one, but one that doesn't sickle. And then there are efforts to actually correct the specific mutation of sickle cell. And just to show one piece of data, this was a publication last year from the trials with Bluebird's anti-sickling beta globin, showing each swim lane is a patient with sickle cell disease, showing pre-gene therapy on the left and post-gene therapy on the right, and each dot is the incidence of a severe vaso-occlusive crisis. So they've gone from many crises per year leading to hospitalization to essentially none afterwards. And the CRISPR approach from CRISPR Vertex has very similar results. So really profound improvement on this very severe disease. So in fact, in this field of lentiviruses with stem cells, there have been multiple successful trials. I talked about hemoglobinopathies and adrenoleukodystrophy and metachromatic leukodystrophy, but a number of other primary defects of blood cells have been treated in at least clinical trials for stem cells. So then just 2 words about gene editing. So now with gene editing approaches, we can try and fix the endogenous locus. And so one approach would be to stick in a whole copy of the cDNA for the relevant gene under its promoter. And so you could override any mutation different patients may have. So using something like CRISPR to make a cut, a double-stranded break, and having a donor by homologous recombination, it can insert into that site and lead to a whole normal copy of the gene run off the endogenous control elements. And then I mentioned one of the newer approaches is base editing, where you can use sort of the Cas9 nuclease to bring to the site of a specific mutation, adenosine or a cytosine deaminase that can change an AT base pair to a GC base pair or vice versa. So you can get very precise correction of single nucleotide mutations. So then I'll just stop by summarizing that novel cell and gene therapies have been developed to treat severe pediatric and adult disorders, such as genetic diseases and cancer and leukemia. These therapies have led to major improvements in patient well-being, notably for otherwise fatal or severe pediatric disorders. These complex cell and gene therapies have been provided safely and effectively at academic medical centers under research clinical trials. However, only a small number have reached licensure in the US and in the EU at least, due more to financial considerations than to technical feasibility. So we need to look at new models to make these available for, as we develop these therapies for more and more rare diseases, what is the business model to make them available? And I will stop there and thank you.
I'd like to invite Dr. Al-Hadi up.
Okay, I'm between you and dinner, so let's get going. So I'm going to really just share my opinion about why I think this is the moment to do precision medicine for breast cancer. I have some disclosures, and this was one of the most amazing families that I met in 1993 before we identified BRCA1 as a major gene for breast and ovarian cancer family. And you know, American Society of Human Genetics has had to discuss about genetics and the importance of genetics in health and disease. And a lot of the times, we don't know quite what to say. Is it black or white? Is it African ancestry? But I want to use real people to give you how my practice in Chicago has evolved and what the families that I have taken care of have actually taught me how to be a human being and a geneticist all at the same time. So when this woman came at 34 it was early on in my career. She did everything we asked her to do, participated in clinical trial. We gave her the red drug, which was the best drug for breast cancer, and she actually had good outcome from her breast cancer. At the consultation, she came with every member of her family who could come to support her and brought a 5-generation pedigree of her family who had their family to hold them together after hundreds of years of slavery. The problem was that my drug caused her to have cardiomyopathy, and she lost her insurance. She was a middle-class black woman, and participated in research to find BRCA1, but could not get benefit of having her ovaries removed because she had no insurance, and then subsequently died of ovarian cancer. And that's really why I was very happy that Mary Claire King helped me publish my first paper on extended African American families, and why I went to President Obama to make precision medicine a personalized approach to cancer therapy one of his major outcomes of his presidency. That was important. And then shortly after really meeting these patients, it became clear that, in fact, by having tools of genomics and being able to do gene expression profiling, my colleagues at the NCI published this amazing paper about ER-negative breast cancer and ER-positive breast cancer. And I had the audacity to actually say, well, it wasn't anything about BRCA1, it was about ER negativity. Cut a long story short, BRCA1 can be methylated, estrogen receptor can be methylated, and you can actually look at the gene expression pattern of somebody with breast cancer. And that really blew open a whole new area of engagement for us in oncology, because we know that breast cancer is not one disease, that if you get the whole genome, you get the expression, and I was really pleased that now we can do cell-free DNA and use methylation markers. So, but at that time, we had to figure out what's going on at the cellular level, and since I really was also very interested in chromosome 9, trying to figure out how a whole region of the chromosome could be deleted and P16 could be methylated, and that was all we needed to do, then it became really clear that it's not just the gene, that you really have to begin to think about genetics and epigenetics, because you couldn't tell the difference between someone who was born with inherited BRCA1 mutation and someone who developed breast cancer because they had their BRCA1 methylated as a first event in the tumor progression. So fast forward, everyone tells me, why are black women dying of breast cancer? And why do we have these disparities in breast cancer? Well, it turns out that everybody died the same way. There was no disparities in the 70s because we didn't have any drugs to treat breast cancer. However, we started doing mammography. There was adoption of tamoxifen, and we know tamoxifen is just not metabolized the same way in everybody, right? And so we discussed the fact that black women have 19% higher mortality from hormone receptor positive breast cancer, despite the fact that they have 22% lower incidence. The mortality for hormone receptor negative breast cancer is twice as high for black women, and that contributes to 40% of overall mortality gap. So as a good card-carrying geneticist who actually practice at the University of Chicago, where we understand population genetics, I began to ask the question about what is this theory of out of Africa early migration? And I asked, is the burden of lethal breast cancer in the African diaspora due at least in part to differences in the distribution of heritable risk factors for the disease? And I really must thank Charles Rotimi for helping me think about how to do the experiment, because he had been pursuing diabetes across the African diaspora. So that's how I started thinking about it. And then, of course, Carol Ober and my husband started thinking about they were going to do asthma, because my husband, as an asthma doc, was saying, why are black children dying in Chicago at twice the rate of white children in Chicago? So we love the city. We love really enjoying the best of the city. If you haven't been to Chicago, come to Chicago. You can imagine how surprised I was when Stephen called me and said, we're sequencing these whole genomes from our asthma consortium, and we find this DNA that just doesn't match the reference DNA. Do you know if these patients had malaria or some odd disease? I was like, I don't think so. But if you align your DNA and you can't find 10% of or 296 million bases, maybe you don't have the right reference. So I was happy that we were able to publish this paper with the Asthma Consortium. And then I started really thinking about how can I do whole genome sequencing of true normal pairs from Nigerian women to get a better understanding of the genomic aberrations that actually propel breast cancer. And to cut a long story short, we know how to do whole genome analysis, but if we don't have the right experiments, we're going to sort of swap out what's really important. So in my lab, I tell everybody we have to first know what's going on in the Nigerian genome, and then we can extrapolate down to everything else, because all the other genomes is really a reflection of that genome that found the foundation of humanity. So that's how we made the discovery that there are so many single base substitutions and indels that actually may be really important in breast cancer trajectory. And if we are able to do that by starting with the African genome, then perhaps we're going to be able to begin to think about how these indels and structural variant signatures can actually help us understand who has homologous recombination deficiency and how we can use it to infer their BRCA type. To cut a long story short, because I don't want to give you too much details, the bottom line is when we compare the Nigerian breast cancer cases, the black women that's in TCGA, and then we are asking what are the types of treatments that we have for breast cancer, we actually find that these women have tumors that are actually likely to respond to therapy. HER2-positive breast cancer was the most lethal type of breast cancer, and now it's become the most treatable type of breast cancer. Triple-negative breast cancer, the same thing. Because of BRCA1 and BRCA2, we have a lot of drugs that would target DNA repair pathway. And so PARP inhibitors came to oncology care, and now we can use it in every tumor types. So the question then is, how are we going to develop biomarker-informed therapies that are more effective and are going to target the right patient with the right drugs at the right time? That's a challenge for us in the future. So anytime you think about BRCA1 and BRCA2, you have to think about, are these genes that we can actually use for prevention? So we did an experiment, take 1,000 cases and 1,000 controls, go to Nigeria, and figure out how many of them have BRCA1 and BRCA2 mutation, comparing cases to controls. And you can see the top gene in Nigeria causing early onset breast cancer is BRCA1, followed by BRCA2. And you can see we didn't believe it, so we went to Cameroon, Uganda, BRCA1, BRCA2, Brazil, which every time Nigeria loses in the World Cup, I become a Brazilian, BRCA1 and BRCA2. And so when you compare them across African American and, of course, the carrier study, which was predominantly white, you can see that this young onset breast cancer are being driven by, number one, top 3 genes, BRCA1 and 2, and PALB2. And then the question is, what's driving the other cases? Because they're certainly getting breast cancer before the age of 50. So that's why we've been interested in looking for other tools to do risk assessment. And I know that the polygenic risk score and thinking about GWAS studies, those are all things that we want to really get to the bottom of. And everyone talks about the fact that we don't have enough samples. But we did actually get sufficient samples to be able to actually ask the questions, because we went back to Africa, where we were really impressed by the number of ER-negative breast cancer that was overrepresented in these young women. And so, cut a long story short, if you're looking at polygenic risk score and whether it's ready for prime time in breast cancer, I would tell you that it probably is ready for prime time, and we have clinical trials that are actually going to test whether we can do population risk stratification. Do we have a PRS for ER-negative breast cancer that disproportionately impacts Black patients? We're going to get there. We're not there yet, but that having a perfect PRS shouldn't prevent us from actually doing some experiments in the laboratory. And so this is a PRS that we can use for ER-negative breast cancer. It actually performs better in African Americans compared to European Americans, because the experiment was done looking at the population that had an enrichment for ER-negative breast cancer. So let's go forward with the one single GWAS hit that we got from our root study. And this is GWAS of breast cancer in Black women. And we had to go to Nigeria, Chicago, Philadelphia, Maryland, anywhere anyone was studying Black women, the big inner cities, to say, give us all your samples. And so with this experiment and then replicating it in the AMBER consortium, we actually found one hit. And that one hit got us to begin to think about TRAIL, which is actually really important in the tumor microenvironment. If you talk to the average oncologist, they will tell you that immunotherapy has totally transformed oncology care, because we know that patients who have an immune system are more likely to respond to immune checkpoint inhibitors. So having a SNP that actually points us into an important pathway for immunotherapy was very exciting for us, because now, because of the understanding of the genetic basis of breast cancer and tumor progression, we now can begin to think about cancer immunity cycle, think about combinations in breast cancer. And for those of you who are doing molecular diagnostics, you know that without molecular diagnostics, we cannot do targeted therapy. We're excited to begin to think about, okay, and what's happening in the clinic now, a lot of patients with metastatic cancer are coming in because we can do the molecular diagnostics. So what happens are a lot of patients coming in, we make treatment decisions, we talk about what they need to do to reduce secondary prevention. And now the important thing is, can we do cascade testing for family members? Because if we find a mutation carrier when you are dying of metastatic breast cancer, that's a failure of prevention. So we are really thinking about mainstreaming genetic testing. We need to make sure everyone in their primary care setting can refer to a genetics expert. And I'm going to end by saying we're doing that. We've asked hospitals in Nigeria and in Cameroon, if genetic testing was available, would you take it? Everyone said yes. Why wouldn't they do it? It's too expensive. So the challenge for all of us here is to make sure that we can develop assays that everybody can afford. Otherwise, we're going to widen disparities. So we need to do cutting-edge research, improve biospecimen collection, use big data to really begin to develop innovative clinical trials. And then we are going to get to personalized care, because it will not be about Black or white. It will be about all of us. This family came to me to participate in clinical trials. They're from Northern Indiana. Once they know that University of Chicago was there, they survived the most aggressive breast cancers. because they participated in clinical trial. So saying that black families don't want to participate or they not want to be included, it's just not true. They want to be part of the solution. Our African partners want to be part of the solution, and our job is to make sure that everybody is included. So on this 75th year anniversary, congratulations to ASHG. We're one human race. Thank you.